Morning, everyone. How's everyone doing today? Good? All right. Well, I'm really excited to have announce or have you here today for our second McGovern lecture in health communication this year. For people who haven't attended any of these in the past, this series now, it used to be one talk a year. We've since converted to a series mainly because we like the chance to bring in more different kinds of people with different perspectives in health communication. But it was established through a gift in 1983 from the John P. McGovern Foundation. We've brought in a lot of folks from entertainment industry, journalists, public health professionals, all of whom have kind of had a lot of different things to share that have always made this one of the highlights of the year for us. As a little background, John McGovern was a noted allergist, scholar, and philanthropist, and he's considered one of the state's and country's most important figures in the history of medicine and healthcare. And he really took a humanistic approach to healthcare. Like he wanted to treat the whole person, which every time I read that, it makes me smile because that is very much how the Center for Health Communication thinks about what good health communication is. Before we kind of kick things off, though, I do want to say thanks to the entire CHC team who works on this. Anyone who has run any kind of event knows it takes a small army of people doing work for a long time. And so thanks to Brianna, Jen, Jessica, Patricia, everyone on our team who builds the promotional materials, the social media posts to make sure we have a nice big audience, both here in the room and all kinds of folks who are on Zoom right now too. So our second McGovern lecture this year is Katelyn Jetelina. She's an epidemiologist and scientific communicator. She is co-founder of the Health Trust Initiative and a senior scientific advisor to several government and nonprofit agencies, including the White House and the Centers for Disease Control. We actually, when I was asking if she wanted to have breakfast this morning, she declined and said she was busy meeting with people from the White House, which seems like a very good reason to skip Kirby Lane if there is such a good thing as moving Kirby Lane for breakfast. She's also the publisher of Your Local Epidemiologist. It's a public health newsletter that translates ever-evolving science to the public, reaching over 300 million views. Dr. Jetelina has received numerous national awards, including National Academy of Science and a Medal of Honor from the U.S. Department of Health and Human Services. I got to meet her about a year and a half ago at the first ever Texas Public Health Summit. Watched her on a panel. It's like I immediately wanted to bring her to Austin to be part of some kind of event. And I've kind of always enjoyed both reading the newsletter and hearing her appear. I think you were on Today Explained about 2 weeks ago. I have a large podcast habit, and so I'm excited to listen to her today at actually normal one-time speed, as opposed to the 2 point something I tend to listen to everything at. So we're really excited and glad you could be here today. So
yeah, thank you. Thanks for having me. Hi, everyone. One silver lining of a pandemic is that you no longer have to explain what an epidemiologist is, that we're not skin doctors. But I'm really excited to be here. I think another silver lining of the pandemic, at least for me, was that I got to be on the front line as an epidemiologist in Texas, as well as the front line on social media. And I've learned a lot along the way. And I look forward to sharing with you some of these lessons learned. So I don't have to explain to you guys what happened in March of 2020 with the virus, but a lot of you guys may not know that when our response wasn't really a response. I put response in quotation marks because I think response means coordinated, and it was all but coordinated. We were scrambling. We were scrambling for data. What is this virus? Who is impacted? Where is it spreading? What is it doing? We have a very decentralized public health system in the United States. So it's impossible to get a national picture in real time. Even today, we're having trouble with that. It's also before dashboards. We have 1 billion of those now these days. We are scrambling for tests, to get tests, to test people, PPE, healthcare capacity. We are scrambling to understand what policies worked. At first, we were really just throwing spaghetti at a wall to see what worked. And last but not least, we were scrambling to communicate. Not necessarily communicate science to scientists because we're trained really well on doing that. It was more of communicating to the public what the hell was going on and what we were seeing in real time and how things were rapidly changing. So this is when my dean asked me to send an email to staff, faculty, and students. This is one of my first emails, about 30 people, me in Excel, not very pretty, a few sentences, but really just bringing people along for the ride, what I was seeing in real time, how I was interpreting it, and what I was doing with my family. I called them your daily driven updates, and I signed them love your local epidemiologist, because that's who I was to these 30 people. I was their epidemiologist at the time. A few days later, after these emails, one of my students came to me and she asked if I could start putting it on social media. So she didn't have to keep copying and pasting these emails to her Facebook to share with her family and friends. And so I was like, okay, what the hell? I'll start a Facebook page. I called it Your Local Epidemiologist, with the goal of closing the loop, translating public health science for everyday use. And I distinctly remember telling my husband, I'll only have to do this for 6 weeks max, because by then someone will pick up the baton and actually start telling the public what's going on. And that never happened. And it really still hasn't happened till today. And now we're about 4 years into this journey. And now I have a newsletter. It's called Your Local Epidemiologist, has a number of subscribers. And I've started talking about public health problems and challenges beyond COVID-19, particularly in spaces and places where there's a lot of conflicting information. There is a lot of data being used in negative ways. And so it continues to be this journey, and I really don't know what I'm doing, but it's been really fun along the way. This past year, I did a survey for my followers, and it's currently reaching 97 countries, and it's reached over 400 million views, this newsletter, which is just wild to me. But like I said, this wasn't planned. It wasn't intentional. I completely stumbled upon scientific communication and knowledge translation. And I find this particularly embarrassing to say in front of an audience of communicators. But this is something I was never taught to do. You know, I love teaching. I was a professor at the time, one of my favorite things to do, but this was very different, right? It was real time, it was public facing, it was going 2,000 miles per hour, trying not to crash into the guardrail. And it was very emotional. It was rewarding, it was exhilarating, it was humbling, it was very scary. But most of all, if I always felt, and I still kind of do feel, like I'm this person in the middle of the forest with a machete trying to find a path forward, because this isn't what public health necessarily does. It's not how we gain respect from peers. It's not how we got tenure. It's not how we get Nobel Peace Prizes. But this is a core reason why I think we did so poorly in the United States with the pandemic, was because this was a key aspect we were greatly missing in public health, was communication with the community. And so right now, my biggest goal is trying to ensure that this doesn't happen again. And so one way I'm doing that is screaming from the rooftops that we need to reimagine public health for the 21st century. And communication touches on literally every aspect of this. So we play an integral role in this. And if we do, we'll save lives. It's literally that simple. So I have a checklist of 5 items that I think public health needs to focus on for the 21st century. And we certainly need your guys' help to get there. So first on my checklist is becoming visible. So public health has always had this idea that if we work in the background, right? If it works, it's invisible. We even have a saying that when public health works, it's invisible. There's actually a 4-part PBS series coming out this week called The Invisible Shield, because the tagline saying public health saved your life today and you didn't even know it. And so the one thing I want to change is that we need to become visible. Being invisible is not working. We have to get out of this mindset. We have to refuse to be invisible for funding, for resources, for trust, for engagement, to get out of this cycle of panic and neglect. And we do that by starting to talk, not with each other scientists, but to the communities we serve, to show our value and our worth. But sometimes, you know, we can't be everywhere all the time. So a lot of the time we need to let the data talk for itself too. During the pandemic, like I said, millions of dashboards were created. The problem was that we weren't very good at storytelling. Presenting the data in a concise and understandable manner ensured that the story we wanted to hear or we wanted to tell gets told, and that didn't happen. The other problem is that literally every other health problem other than COVID needs a lot of help in this area. So for example, I'm part of the measles response team at CDC, and this is currently the measles website. This is their data storytelling, and we don't know who's getting infected. We don't know what's being prevented. We don't know who's at risk. We don't know why this is increasing in 2024. And this is a really low-hanging fruit where we can have the data start telling this story and driving the national conversation and creating something that's very useful for people to understand in real time. But becoming visible means we need to change, public health needs to change its culture and our incentive structure and how we do this. Again, we are not trained in scientific communication, so we need to integrate communication in our training. It's just not viewed as a core, and this needs to change. I think we also need to integrate it in practice. So for many organizations like local health departments, this means creating a scientific communication workforce. Officials must recognize that communicating to the public is an essential part of the mission, the energy and time allocations that are needed. Something that I've discovered at my work at CDC and the White House is, sometimes there's actually really great two teams. There's a great comms team, there's a great science team. The challenge is that the bridge between them is either broken or incredibly challenging to get across. Because of clearance processes, because of lack of internal trust with each other's teams. And so this discourages frequent information sharing and can erode key messages in the end. So number one, we need to become visible. Number two, we need to place public back into public health. What do I mean by this? Well, we need to open up a two-way street with the public, and communication is core to this, right? So as epidemiologists, especially during an emergency, we do a lot of telling. We do a lot of telling because time is lives, but we really need to slow down and open up for bi-directional feedback with the community. And this is hard to do, but audience is not merely a target, it is an active participant. And listening is different than hearing, right? Hearing is much easier because it's involuntary, no conscious effort is required, but listening is much more impactful and it involves the mind and of course the body. It's important to also recognize and acknowledge that legitimate concerns do exist, that we have failed groups in the past, especially certain groups around vaccines, and we need to approach questions from a level of empathy. And we not only look for questions or listen for questions, we have to actively look for questions. Be proactive. On social media, people are asking thousands of questions a day. So much so that I actually had to create a database that brought in and read all of the themes of questions I was receiving so I could create content that answers those questions. One of the reasons I think my newsletter was successful was because 90% of the content on there is not what I think is interesting or important. It's actually what people are asking and me being responsive to that. And I think that's really, really important to be responsive to the conversations on the ground. And then of course, to know where people are talking, and I'll get into this in a little. Part of opening up a two-way street is listening, not just during emergency times, but most importantly during non-emergency times. And we call these peace times in epidemiology. We need to listen to communities to understand what their concerns are, not where we're getting funding and what our concerns are, and show up during these times to have brownie points to then spend when we need a lot from them and we're asking a lot from them during an emergency. Part of putting public back in public health is learning how to translate, and this is really challenging for a scientist to do. But people don't know what myocarditis means. They don't know what bivalent means, and they don't necessarily shouldn't know what these means, but they have the right to understand. And so we need to slow down and think big picture. I love the quote from Albert Einstein that says, if you can't explain it simply, you just don't understand it well enough. As experts, public health officials, we have a deep knowledge of a particular subject. And I would argue that we actually have too much knowledge sometimes, that we get boggled down in the weeds. And so what I have found is that scientific communication is truly this art form, or this balance between nuance and readability or understandability. Our ability to communicate uncertainty, statistics, all of the scientific jargon, while understanding that people need to act, they need to understand, and they need to be able to read it. One of the biggest lessons I learned throughout the pandemic was never to underestimate the public, that they can learn these things. It's actually our fault that they're not learning these things. Show the human side. So putting public back in the public health equation also means that as communicators, especially public facing, we need to show that we're humans. I think this is another reason why my newsletter was successful, was because I was an actual person. I was a face, I was a warm body, I was a consistent voice, I was credible, and I made a ton of mistakes. And I think that's okay as long as it was owned up and people saw that it was organic and it was real. I was also talking people through how I was thinking about risks, how I was doing things with my family, how difficult things were, and how frustrated I was at times, that people could relate with that. This is something I think the CDC missed sorely on, that it was a huge brick wall, and no one listens to a brick wall. Why would they? Why would they trust that? WHO actually, I thought, did this fairly well with Maria, Tedros, and Mike. Every week they showed up, and every week we knew what Maria and her kids were thinking that week, and going through, and she was very good at translating as well. So this is really another low-hanging fruit. We can certainly do better in the future. But sometimes it's actually best not to hear from the expert, not to hear from the ivory tower. No one cares what Dr. Katelyn Jetelina on PBS NewsHour is saying, right? But instead, what we need to do is equip trusted messengers. And these are pastors, they are teachers, they are NASA scientists, they are physicians. They are people in the community that they trust. One of the most eye-opening things about my newsletter is I always thought I was talking to Joe on the corner, and that is actually who I was not talking to. I was talking to trusted messengers who then curated that information and sent it through their network. And so I was one node in this large grassroots information diffusion network. And this grassroots bottom-up sort of communication is just as important, if not more important, than the top-down. Putting public back in public health is also recognizing it's not just what we say, but how we say it. What you say matters. How we communicate correct information matters. The words we use matter, especially the tone and the details matter. So one way I want public health to reimagine themselves is to be truly inclusive. Johnson and colleagues did this wonderful network analysis of vaccine information on Facebook pages. And this was one figure in their paper. But there's three things to notice. One is that there's clear echo chambers. So these blue dots are pro-vaccination sites. These red dots are anti-vaccination sites. And these green dots are undecided. So parent-teacher association Facebook pages, for example. And so clearly blue is separated from red. I don't think anyone's very surprised about that we have echo chambers on social media. The second thing is that there's actually far fewer red dots than blue dots, but red dots have more followers. They have higher, farther reach than the blue dots. But I think the most important thing here is that red dots, these anti-vax Facebook pages, are far closer to those green dots than the blue dots are. And so what this means is that pages that explain the benefits of and the scientific case for vaccination are linked in a network that's largely disconnected from the main battlefield of sentiment, that we're just talking to ourselves, that we're not reaching out to the concerns on the ground, and it's not effective in that sense too. Part of being inclusive is, like I said, recognizing what you say matters, especially to people who are hesitant or to believe in conspiracy theories. So using words like dumb or absurd or insane, they're not empathetic, and all we're doing is challenging their worldview. And when we do this, people will double down because their worldview is part of the tribe they're a part of and the groups they're a part of. And we need to set new foundations of trust. Number 3 on my list is get with the times. So the information landscape is changing. I don't need to tell a room of communicators this, but people are no longer getting their information from the news. This is a very, public health thinks very old school on how to get information out there through media interviews, et cetera. But only 30% of Americans trust in the news overall. We have social media, and it's a huge part of how people get their health-related news. In the United States, about 70% of people get their health-related information on social media. Part of getting with the times, though, is knowing where people are talking, but also understanding that social media and the internet is this place where misinformation can spread really rapidly. For example, this study done in 2018, so before the pandemic, showed that misinformation goes farther, faster, deeper, and more broadly than the truth. False news reached far more people than the truth, was more retweeted by the truth. False news spread 6 times faster than the truth. It was retweeted by more unique users, and it was diffused more broadly than the truth. And so to me, these findings show that the new light of the fundamental aspects of our online communication ecosystem. Also, we have to recognize that AI is here, right? And AI will accelerate the speed, reach, complexity, and innovation of communication. And this can be a really good thing. We can use these tools to maximize our capacity, but it also can be a bad thing for disinformation and misinformation and rumors. The thing I'm most concerned about is this new era where we don't know what is trustworthy, who is trustworthy, and these questions are going to get more difficult over time. A prime example emerged a few months ago with the AI-generated image of explosion at the Pentagon. And this actually impacted the stock market that day. And this was just one example of new AI images that will have detrimental effects. Selfishly, I also think that AI will diminish the safety of public-facing people on the front lines of communication with deepfakes. And it'll be impossible, again, to discern what is true and what is not true. I'm trying to be optimistic about this, but we'll see how it goes. And a lot of resources are going into misinformation, right? Bills, FDA, libraries are starting to train people. Schools in Finland are teaching students how to generate and spot misinformation. And if you asked me about a year ago, I'd be like, great, right? This is all we have to do, end of presentation. But the challenge is there's always going to be bad actors. There's always going to be a game of whack-a-mole, and there's always going to be opinions. And so how do we get ahead of that? How do we prevent that? Well, we need this reactive communication, which I call it, but we also need proactive communication. So bring people along for the scientific discovery ride. And this means walking people through what we do know, but even more importantly, what we don't know, and how are we finding these answers? This was something that we gravely missed during the pandemic as well, because at first, hey, the vaccines worked fantastic with preventing transmission. We didn't talk about how we don't know how this virus is going to mutate over time to decrease that effectiveness over transmission. And so people in the public have a really hard time shifting opinions and understanding where those shifts are coming from if we don't let them anticipate with us as we go on this journey. Part of being proactive is being first, right? One of the biggest gaps is timeliness, especially from government. Messaging is too slow and too scant to meet the need of the public to make decisions today, especially for emergencies. And we just need to get way more comfortable communicating quickly, continuously, and with empathy. And then, of course, focus on being proactive is anticipating concerns. It took us, for example, 9 months to develop a COVID-19 vaccine, and that means we had about 9 months to prepare. None of that happened. We were then very surprised when 40% of Americans wanted to wait and see what the vaccines were doing. And we didn't anticipate these concerns, certainly not on a national level, that people will have questions about mRNA because they don't know that doesn't change their DNA. And they have questions about fertility because pregnant people weren't involved in the clinical trials, all really legitimate questions that they couldn't find answers to. The fourth thing on my list is, and I always get tomatoes thrown at me on this one, but to embrace politics. There's a strong desire in science, but specifically public health, where we want to avoid politics. Historically, the political system is commonly viewed as subway's third rail, right? Avoid touching it lest you get burned. Yet this third rail provides power to the train. Public health goals depend on sustained and constructive engagement with the political system, especially responses during an emergency are human endeavors led by people put in places through political processes. So public health is inherently political. Communication can help immensely with this, right? Not just engagement, but understanding that and coming to policymakers with the understanding that policy isn't just based on science, that we can avoid partisanship, that we can be forthcoming about value judgments, and that we need to choose the right battles, make strategic choices on which battles to fight, at what time, and at what level of government. Political capital is as scarce as financial resources, and it really needs to be allocated carefully. Communication, particularly with policymakers, is incredibly important, particularly around knowing your audience. I know you guys know this, but scientific language is very unfamiliar to policymakers, and evidence is very inaccessible. So how we frame issues matter. Who we talk to when really matters. For example, there's this I was talking to a Republican senator the other day, and he was like, Katelyn, stop using the word pandemic preparedness. This doesn't ring true for me. What really rings true is using the word biosecurity threat. They're the same exact sort of word, but they come from different areas and needs and levels. And so we just need to be smarter on how we talk about public health to policymakers to get things done and to align. And then finally on my checklist is innovation. In order to reach every single household in the United States, we need to build the capacity to communicate to them. We do not have the capacity to do this in public health. We barely have the resources to be responding to measles outbreaks right now. And so to me, how do we innovate to increase capacity? So for example, can we have more public-private partnerships with Google, for example, or with heat-related illnesses? Can we work with the National Weather Service? Can we work with the weather apps on Apple? Another innovative idea is thinking through entrepreneurship. I'm not sure where entrepreneurship lays within health communication, but there is zero entrepreneurship in public health. It's just not a way we think about things. It's not a way we approach things, but it can make huge strides. So for example, a lot of the wastewater surveillance is through entrepreneurship. We can also create design studios to help health communications centered around product development or technological advances in AI, for example, to increase capacity. And a part of innovation is creating the infrastructure. So from my side of the aisle with public health, there's really nowhere for public health communicators or practitioners to live, at least the thing that I was doing, right? The federal government, there's a lot of politics involved. There's a lot of confusing guidance. There was a lack of communication. Academia was a fantastic partner throughout the pandemic, but they're usually really slow and scientists are very difficult to understand. And for-profit, right? Even mass media, some people think some have lost objectivity and their partisanship, and there's certainly conflicts of interest, for example, with pharma companies. And so I've been thinking very closely on where does a community of practice live and where can this information exchange hub be between communicators and scientific expertise to then have information diffusion networks that can be activated in an emergency, but also during non-emergencies as well. So this is my checklist to save the world. But really, I think that this is something that public health needs to really start chipping away at. And communications plays an integral role at literally every part of this process. So, whether that's integration into practice, two-way street, translating, equipping trusted messengers, being inclusive, knowing your audience, recognizing how to reach people, and even building capacity. So I invite you guys to insert yourself in any or all of these aspects. Help ruffle feathers, help change the status quo in public health, bring big, drastic changes and ideas. It's literally the only way we're going to start improving trust very quickly. And ultimately, to me, it will save lives. So thank you.
So I'm going to ask you a first quick question, and then we'll open up to everyone else in the room, and I'm starting to get questions on Zoom also. I'm curious for the kind of conversations you have. A lot of states temporarily learn some good communication lessons. So we not any state in particular, just lots of states, resisted using, local influencers or celebrities or people who have existing audiences to help them spread the message about COVID. And now that COVID is definitely not over, but we're past it. We seem to have forgotten those lessons when it applies to good communication around lots of other health issues. So do you have any thoughts on how to help kind of governments and policymakers actually just remember things they did temporarily learn and change their behavior on so we can go back to some of those things?
Yeah, I mean, I think that's a hard question. So, I mean, I think one is this is a huge concern to me is sustainability or maintenance over time, because it feels like, at least us in public health, and it sounds like communicators, that we're going back into this cycle of panic and neglect. And how do we maintain and sustain these resources when we have very few resources? And one of the biggest concerns I have is the leverage and the equipping community health workers. And they were integral in getting people vaccinated in the community. However, now all the resources are drying up, and they feel like they're being put to the wayside, and they kind of are. And that concerns me most about next time that we want to leverage them. And so I don't know the right answer to that. I think that part of it is using language from policymakers to understand that this is a problem. Why is this a problem? I think it's going to take a lot of leadership from government to help fund infrastructure grants, for example, to have a communicator at local health departments. Right now, people are just trying to get by with very, very few resources. And so what seems like fluff is just being taken away, and it's gonna hurt us for the next our next response.